The last speaker will be Dr. Levine from Cleveland. He'll be talking to us about posterior column and the associated variety posterior wall plus posterior column.
It's my pleasure to talk with you briefly today about the posterior column and posterior wall acetabular fracture. My hope is that at the end of my talk today, we'll have a better understanding of the pathoanatomy of the posterior column with or without the associated posterior wall fracture. We'll understand some of the radiographic findings typical of the posterior column and posterior wall fractures. And at the very end, we'll talk about some of the reduction techniques and fixation techniques that we commonly employ when taking care of injuries. Fractures of the posterior column are those in which the posterior column is detached as a single large fragment. This leaves the anterior column and the ilium remaining as one intact segment. Typically, the femoral head will displace with the posterior column fragment. Overall, these form a relatively small subset of all acetabular fractures as seen in several large series, but it's really a critical fracture to understand because it forms a component of the associated both column fracture and T-shaped fractures that we'll talk about later in the lecture series. So the posterior column fracture originates at the sciatic notch. It then takes an oblique descent down the acetabular surface. It typically crosses the caudoid fossa in its most posterior region, and then finally disrupts the ischial ramus at its mid portion, but of course this is variable. Looking at the internal surface of the pelvis, the fracture will descend obliquely and then vertically down the quadrilateral plate and exit the inferior ramus. Correlating these patterns on an AP view is really critical. And as we heard in Dr. Sims's lecture about the radiographic lines, we would expect that the iliopectineal line would remain intact, indicating the integrity of the anterior column. The roof would be maintained in its normal position. The anterior rim and anterior border of the acetabulum will be unaffected. The teardrop typically remains intact. However, if we recall back to Dr. Sims's talk about the radiographic condensation of the teardrop, typically this is formed by more anterior structures. And so if this fracture line exits posterior to that, we would expect that the teardrop would remain intact. If the fracture line were to exit more anteriorly in the acetabulum, perhaps we would see some disruption of the teardrop. And we'll see an example of that later. We can see that the posterior column is one large fragment. It's medialized and internally rotated along its vertical axis. We can see that the sciatic notch and the ischial spine is really highlighted here. Typically, the posterior horn of the articular surface remains congruent and attached to the posterior column fragment. And the ilioischial line is broken and displaced medially. Typically, the head will travel with the large posterior column fragment, and this is because the posterior capsule is typically intact, and that's an important distinction. Looking at an obturator oblique view, we can again verify the integrity of the anterior column and the anterior portion of the acetabulum. The roof remains intact, and this view really highlights the exit point through the ischial ramus. Looking at an iliac oblique view, we can see the posterior column fragment is clearly displaced and highlighted. We can see the cranial exit point of the fracture at the sciatic buttress. We can see that the roof is intact, and we can see the anterior column and the anterior rim of the acetabulum is intact. Correlating this to what we would see on an axial CT scan, we can clearly see the separation of the posterior column from the innominate bone. The posterior column will be posteriorly displaced and internally rotated. The femoral head will remain in congruity with the posterior articular surface. It's very common to see some fragmentation or comminution along the fracture line itself, and it's important to recall that this does not represent a true posterior wall fracture as the posterior capsule is intact. Here's another example of an elementary posterior column fracture. Again, we can see the continuity of the iliopectineal line, the intact roof, the intact anterior border of the acetabulum, the large posterior column fragment that's medialized and internally rotated, the intact teardrop, the intact posterior horn of the articular surface that's in contact and continuity with the posterior column fragment, and the broken ilioischial line. Looking at an obturator oblique view, again, we see the integrity of the anterior column, the attached roof, the attached and intact anterior rim, and the fracture line exiting the ischial ramus and the large posterior column fragment. Again, we can see some comminution, but again, this is not representative of a posterior wall fragment. Looking at the iliac oblique view, we can see nicely highlighted the posterior column fragment, the intact posterior articular surface that's still attached to it, the intact anterior border of the ilium, and that's confluent with the anterior rim and anterior column of the acetabulum, the takeoff point at the sciatic buttress, and some comminution there. And finally, we can see the intact roof. I think there's an interesting variant of the posterior column fragment that posterior column fracture that, while rare, I think highlights some of these radiographic changes and helps to kind of bring things together. So I'll draw your attention here to this area marked with the double arrows. And Dr. Sims mentioned this particular type of fracture where it appears that the iliopectineal line is rarefied there, or perhaps broken. And one might wonder if this is something more than just a posterior column fracture. And we need a little bit more information to determine what we're dealing with. And so again, we can see here in this example, the posterior column fracture, the posterior column segment is medialized. And the interesting thing here is that the teardrop has medialized with the posterior column. Looking at an obturator oblique, we can verify that the anterior column of the acetabulum is intact. And looking at an iliac oblique, we can see the large posterior column fragment here. If we were to put this all together, looking at a CT scan, with the blue arrows, I'm highlighting the integrity of the anterior column through each sequential slice. And if we look at the yellow arrow here, we can see the relatively anterior position of the posterior column fracture line. Putting this all together in a diagram, we can kind of have an understanding of why we see what we saw in the plane films with this very anterior fracture of the posterior column. And so we can kind of understand why the teardrop might be affected in this particular pattern. And if we look on the internal surface of the pelvis, we can see that the pelvic brim is just touched by the posterior column fracture, and that's why that iliopectineal line was affected. However, this is still a posterior column fracture. Moving on to the posterior column and posterior wall fractures. Again, overall, a fairly small subset of all acetabular fractures. Again, the anterior column and the ilium will remain intact. The posterior column in these fractures can be incomplete or minimally displaced. If we look at this on a pelvis, the anatomy of the posterior column fracture is essentially identical to that in the elementary group. And the fracture of the posterior wall can have all the features of any posterior wall, that being, it can be multifragmentary, it can have marginal impaction, and these are all issues to identify and address intraoperatively. Unlike the elementary posterior column fracture, here the femoral head will displace with the posterior wall fragments as the capsule is disrupted. So here's an example of a posterior column and posterior wall acetabular fracture. We would expect that the iliopectineal line would remain intact. Here we can see a broken or disrupted ilioischial line. The teardrop has here remained intact with the posterior column segment, and we can see the posterior column fracture hiding behind there. The anterior rim we would expect to be intact. And here we can see that the posterior rim is disrupted. On the left, we have the obturator oblique view, which nicely highlights the integrity of the anterior column. It highlights the posterior wall of the acetabulum that's fractured, and we can see the ischial exit point. On the iliac oblique, we can see the large posterior column fragment and its exit point at the sciatic buttress. Also, we can see the continuity of the anterior rim to the whole anterior portion of the acetabulum. And hiding behind here, we can see the posterior wall fragment. So to compare and contrast these two injuries, in the isolated posterior column, we would expect that most of the energy has gone through the posterior column, and we can see that the column can be highly displaced, whereas in the posterior column, posterior wall, the column is typically less displaced, but the wall is often highly displaced. In the isolated posterior column, the femoral head remains congruent with the posterior column because remember that soft tissue, the capsule, is still intact. Whereas in the posterior column, posterior wall, the femoral head is no longer congruent with the posterior column. Now it will fall backwards with the posterior wall. In the posterior column, we see that the femoral head is centrally dislocated, whereas in the posterior column, posterior wall, the femoral head is posteriorly dislocated. On an axial CT scan, we can see on the right, the head remains congruent with the posterior column and will medialize and internally rotate, whereas on the CT scan on your right, we can see that the head will fall backwards with the comminuted posterior wall. Here's an example from my institution just about a week ago, where we can see a fairly comminuted posterior column and posterior wall fracture. So in blue here, I've highlighted the integrity of the anterior column. The yellow is showing us the fragmented posterior wall, and highlighted in yellow here is an area of marginal impaction. And in red, we can see the origin of the posterior column fracture. And as we move more caudally, we can see that the head is tending to fall backwards with the comminuted posterior wall. Finally, we can see the exit point out of the ischial ramus. Typically, as we've just heard, the posterior wall, of course, and the posterior column with posterior wall is typically addressed through a Coker-Langenbeck. These are often done in the prone position. Lateral position is possible. However, I would caution you, as the leg and the hip are a medializing force, and this may make reductions more challenging. If we recall back to Dr. Rout's excellent osseous fixation pathways talk, we know that we can fix the posterior column in a variety of methods. The posterior column can be fixed if non-displaced or minimally displaced, perhaps through a small lateral window in an antegrade fashion or in a retrograde fashion through the ischium. Either way, it's helpful to have some kind of distracting force, either through a Schantz pin in the femoral neck and femoral head or a femoral distractor. There's a number of reduction tools that are often used to reduce the posterior column. Something like this angled pelvic reduction clamp can be used. Often a Schantz pin is placed in the ischial ramus to help manipulate the posterior column. Something like a bone hook, a pointed reduction clamp through unicortical drill holes can be helpful. Screw-based clamps, such as this Faribault or a Youngbluth clamp, can be used. This has the advantage of being able to distract the fracture, debride the fracture, and then clamp. Remember that any of the screw-based clamps, the vector of the compressive force is based on the position of the screws. So it's really critical to pay attention to the orientation of the fracture line and to have your screws placed as perpendicular to the fracture as possible, so that when you compress, you don't induce shear in the fracture and potentially make the reductions more difficult. An additional difficulty with the screw-based clamp is not only the additional traffic that's induced by having these screws in the clamp there, but the position of the screws also is important. And you can see on the image on the left, if we angled our screws towards the fracture, as the fragment reduces to the clamp, even though the surface visible to us may appear to be reduced, we're in fact gapping the fracture at its far surface. Therefore, it's really critical to be able to palpate over the quadrilateral surface and feel the reduction to ensure that it's anatomic. Once we have an appropriate reduction, it can be held in a number of ways. We can use something like a Steinman pin. A small plate can be placed to hold a provisional reduction while further reduction is attained. Something like this lag screw can be used in a posterior column fracture. However, I found this to be very difficult because of the obliquity this fracture typically takes. And so it's hard to get the right angle for a good lag screw. For a elementary posterior column fracture, the fixation that we employ can be something like this, like a pelvic reconstruction plate that's contoured for the posterior column, fixed above and below. Typically for a posterior column with a posterior wall, 2 plates are employed, one to initially hold the column reduction while the wall is reconstructed and then buttressed down with this reconstruction plate. And this may also involve the use of spring plates like Dr. Johnson just nicely showed us. One more advanced technique may be something like a plate and retrograde screw type of fixation. So in summary, we've talked about the pathoanatomy of the posterior column and posterior column, posterior wall acetabular fractures. We looked at some of the radiographic findings that are common in these fractures, and then we ended up learning about some of the reduction techniques and fixation techniques that we employ. Thank you very much.